Okay. Good morning, everybody. I'm going to go ahead and get started. Got a decent amount of material to cover. Very exciting topic, biomechanics, metallurgy, and implants. We're going to focus on a more clinical application of some of these concepts. As far as overview goes, we're going to look at some basic science, and then we're going to break this into essentially two different groups. The majority of the discussion will be on the fusion group, looking at rods, screws, different type of surface treatments, and different interbody concepts. And then we'll look briefly at arthroplasty implants, both cervical and lumbar, more of an overview of their design. With respect to basic science, an important concept that we'll talk about a lot is the Young's modulus, essentially the stiffness factor of various materials. And a lot of the time, it's important to remember that these are anchored with respect to bone, both cortical and cancellous. So if you look at the graph on the right there, all the way to the left is cancellous bone and cortical bone, showing essentially their stiffness with respect to things like PEEK or carbon fiber reinforced PEEK. Other things like stainless steel and cobalt chrome, as well as titanium, are going to be the vast majority of what we talk about. You can see that those are a lot of times lower modulus of elasticity than some other materials that you'll see. Titanium does have a significantly higher modulus than cortical bone, but it's less so than stainless steel and cobalt chrome. So you're typically going to see those as more stiff materials, and then titanium a little bit closer to bone, and then PEEK is very comparable to bone, relatively speaking. There's a table that looks at some of the different properties of various materials we'll talk about, the big ones being stainless steel, titanium, and cobalt chromium. It's important to note that stainless steel and cobalt chromium, like I mentioned, are less malleable and really used, especially cobalt chromium, especially deformity, when you want to maintain stiffness of your construct without any deformity of the alignment. And then titanium is much more malleable and PEEK even more so. Looking at various different implants utilized in fusion, historically, there's a lot of different implants to choose from, both autograft, allograft, as well as some synthetic implants we'll discuss. The primary goal was always been to provide some mechanical stability, but over time, that's shifted to not only providing the mechanical stability, but also inducing fusion across the interbodies, as well as providing some improved alignment as a secondary component. So secondary goals of instrumentation are the stabilization of the neural elements, the indirect decompression, and avoidance of complications. And really, alignment should be included in this list as well, although you could argue that that's a primary goal as a 1A and 1B with stabilization. Looking at rods, this is an early rod that was developed by Paul Harrington, made out of stainless steel. Modern rod constructs typically utilize titanium or cobalt chrome, especially for deformity surgery, with PEEK as an additional option, although PEEK is less popular. Titanium is by far the most popular option. It's most similar to bone with the modulus of elasticity. It's got a really good biocompatibility and minimal artifact on MRI, although PEEK has the less artifact overall. Cobalt chrome, significantly stiffer than titanium, as we all know, more biocompatible than stainless steel. Utilized primarily in deformity applications. It does have a significant amount of metal artifact, but still less so than stainless steel. PEEK is very similar to bone, but this is important because it can provide a greater load sharing between the interbody as well as the end plates. It's radiolucent, which is advantageous for postoperative imaging. And then it does have very big limitations with respect to rod contour and bending ability. Overall, looking at rod contouring and biomechanical strength, this is something that Dr. Mundis talks about frequently, as I'm sure do a lot of the other guys. Looking at intraoperative rod bending with respect to notching and the reduced stability overall. And the thought is that notching increases the risk of rod fracture, and therefore pre-contoured patient-specific rods may then decrease that risk. So this is a biomechanical study out of spine with looking at 6.0 tie rods as well as 5.5 cobalt chrome rods, looking at their ultimate load strength after bending with the rod bender. The cobalt chrome had significantly higher stiffness compared to the titanium, but the notch-free cobalt chrome had even higher ultimate load than the notched cobalt chrome and the titanium alloy rods. So you can see in the graph there, the two options on the right, the cobalt chromium notched and cobalt chrome notch-free. once it's notched, it's about pretty comparable to the titanium that's notched as well. Moving on to pedicle screws, I just wanted to focus on a couple biomechanical factors that may be applicable with these instruments. Essentially, they're the standard of care. I think pretty much everyone is using them at this point for fusions. They're designed to transfer the posterior column forces through the middle and anterior columns to help spread that support and allow some better fixation, especially anteriorly. And this can also aid in corrective maneuvers intraoperatively. The vast majority of these are titanium alloy. There is loosening and pullout, which is a problem, especially depending on patient bone quality, which is why there's so much focus on that perioperative treatment of osteoporosis. And then they've done a lot of different things with respect to the design and biomechanics to help increase the overall effectiveness of these pedicle screws. So attempts to decrease screw loosening, pull-out failure. These are things like surface treatments. We'll talk about hydroxyapatite in a second, calcium phosphate, tantalum titanium plasma spray, as well as cement augmentation. Looking at the depth of insertion is important. It's something that we're always talking about when we're planning preoperatively, trying to get an adequate screw size or as long as a screw as possible. This was a cadaveric study that measured failure strength under flexion or torsion loads, as well as pull-out strength. It was a comparison of opposite pedicle screws. So they basically cannulated bilateral sides of a vertebral body and then compared 50% of the insertion depth to 80% and then 80% to 100% of the maximum available depth. Essentially looking at is a longer screw with more purchase in the vertebral body better. As expected, they did find that it was better to have more screw inserted, and we're able to put some numbers to that. So about the failure strength at 50% depth was about 75% of 80% depth. And then at 100% depth was about 125 to 150% of the 80%. So essentially, as expected, longer screw is more strength. And then they allotted 26% increase each 5 millimeter increment. So when you're debating to go up or down a size, aside from the anatomic constraints of the bone and everything, you can add about 26% fixation strength with each screw size. This was looking at biomechanical strength of pedicle screws, specifically with thoracolumbar burst fracture, which is something that we all encounter frequently. Looking at whether or not the fractured level is instrumented, they had a prospective randomized study of 80 patients, randomized into 2 groups. One was 1 level above, 1 level below, including the fracture site. And then the other was the same, but including the fracture site. They had about 40 patients in each group, showed similar outcomes overall. There was a high rate of instrument failure in the bridging group, and they also showed worse kyphosis in that group overall. The group that included the fractured level actually improved by 6% with respect to kyphosis. And then essentially they found that this was most prominent in type C fractures. This is another study looking at the effectiveness of pedicle screws, very similar in a short construct. And essentially, they found that the inclusion of the pedicle screw at the fracture level had different effects for both short and long construct. And short construct, this increased the stiffness of the construct, but once you were already utilizing a longer construct, the addition of that extra pedicle screw had very little difference on the stiffness of the overall construct. Other ways to kind of aid or look at the biomechanical application of pedicle screws would be cement augmentation. This was a literature review looking at the biomechanical analysis. They thought that cement was an effective material to enhance fixation in osteoporotic patients or revision surgery. And they did note a small benefit similar to screw fixation of pre-filling with the solid screw. So they looked at cadaveric models. Cement augmented screws were able to be removed, but they did require higher extraction torque. They did note that there's no catastrophic damage to the vertebral body. So essentially, you can get more fixation without catastrophic damage on the way out if needed, which is a pretty big limitation overall. There was a limit to the study in that there was limited cyclic loading and no time for bone ingrowth or ungrowth with respect to the screw. Again, looking at bone cement, this was a retrospective study of 241 patients with osteoporosis and pedicle screw fixation. They essentially divided them into unaugmented and augmented groups. The augmented group was subdivided into solid screw augment versus fenestrated screw augment. The solid screw is where they placed the cement into the cannulated or tapped pedicle track and then just inserted a solid screw behind it. Fenestrated screws as described. They placed the screw and then inserted the cement through the fenestration holes. They did note that a similar screw loosening between the two when comparing groups 1 and 2, but then cement leakage, screw loosening, and screw fractures were less in the overall group. The fenestrated screw group had a higher rate of screw fracture, which is as expected with you have holes in the screw compared to a solid screw design. It's going to have a lower failure level. So they noted the incidence of screw loosening was 50% in group 1 and 7% in group 2. So the unaugmented versus augmented, which was statistically significant. Other significant findings were cement leakage, although none of those were clinically symptomatic. Screw loosening was in 6% of the solid screws versus 1% of the fenestrated screw. And then screw fracture were none in the solid group, and then 3 in the or 5% in the fenestrated group. Again, expected to have a lower tolerance or strength with the fenestration holes. So how can we kind of augment some of these implants, especially the ones that are physically going into the bone as compared to rods? So this is a couple slides on surface treatments that have been utilized in the past. This study looked at 12 mini pigs evaluating bone integration with different type of screws. They used micro CT, pull-out strength, and stripping torque, as well as a histological analysis at 1 and 3 months to further evaluate that. They used both smooth surface screws as well as ones with a sandblasting treatment, and then also ones with acid etching, which they described as the SL affinity. The micro CT showed gaps between the bone and implant in the sandblasted only, as well as the smooth groups, and smooth groups compared to the SL affinity at 1 and 3 months after implantation. The removal torque and pull-out strength were both higher at 1 and 3 months in the SLA affinity group. And this also had a higher mineralized matrix, as well as most bone formation around the screws and the most bone cells in bone tissue on histologic analysis. So overall, pretty promising results. This looked at essentially nanopores of 20, 30, and 50 nanometers in different volts and two different acids, looking at cell differentiation and osseointegration. Essentially, they found that the 30 and 50 nanostructures promoted early osteoblastic gene differentiation, so different type of cells as well. And then this was compared by implantation to rat tibias at 1 and 3 weeks. The nanostructures significantly accelerated bone apposition and bone bonding strength in vivo, and that correlates with in vitro results that have been seen historically. This is another very common method, especially with respect to iliac bolts, but this was a smaller sample size study looking at different pedicle screw treatments. So this was 7 patients with hydroxyapatite coated screws and 4 of them, so essentially half of them were removed approximately 1 to 2 years later at 10 or 22 months. They found that the mean insertion torque was significantly greater in the hydroxyapatite coated screws than the standard screws, so 100 versus 76. And then also the extraction torque exceeded the range for the torque wrench, even though the standard screws were already loose. So this significantly improved the purchase of the hydroxyapatite coating, significantly improved the purchase of the pedicle screws, but also made it more difficult to extract than the conventional stainless steel screws, which were subsequently already loose. So this is a plasma immersion ion implantation technology. P3 or PIII, depending on how you want to say it. But this was looking to improve surface properties without altering the actual mechanical properties, essentially creating an additional layer that doesn't delaminate easily. The rats had the implants placed and were sacrificed at 8 weeks postoperatively, and then the surgical sites were analyzed more closely. Essentially, it was a surface treatment protocol for peak. And what they found was that the bone itself was more highly mineralized at 2 weeks, and the elastic moduli were consistent with that and the histologic samples. With respect to interbody cages, they serve multiple functions. They can restore anatomic height of vertebral disc, restore the collapsed disc space, stabilize the intervertebral space, and then allow fusion from end plate to end plate through the cage, as well as on growth of bone from vertebral body end plates to the cage itself. They've used plenty of different biomaterials in the past, including allograft, titanium alloy, ceramic, PEEK, titanium-coated PEEK, 3D printed titanium. We'll go over all those shortly. Some pictures looking at different iterations of what that has looked like over time. With respect to allograft, this is a historical description going back to 1955. These typically are associated with donor site morbidity, graft reabsorption, and graft subsidence, leading to alternative materials. Looking at femoral cortical allograft rings described in the late 1980s and 1990s for use in ALIF, and then other designs subsequently after that. This study looked at ACDF. It was a retrospective review based out of UCSF for patients undergoing PEEK versus structural allograft and plate fixation with minimum of 2-year follow-up. They had 60 PEEK and 100-ish allograft patients, and essentially they concluded no statistically significant difference in pseudoarthrosis rate, revision surgery rate, subsidence, or lordosis loss between PEEK cages and structural allograft. Looking at different materials of the interbody cages, this was a study that looked at 5 different factors to assess subsidence. They looked at a variety of different cervical cage morphology, material, and substrate density. With respect to the cage subsidence, their low versus high density substrates were looking at cancellous or were designed to mimic cancellous or cortical bone as well as different bone qualities. They found that lower density and smaller footprint had significantly more subsidence, and then size in the higher density, the effect of size was lessened with better quality bone or the more cortical type bone. And then with respect to material, the higher density showed no difference. The lower density PEEK and titanium had more subsidence, and there's no difference in texture at both high or low density. But with low density, the texture did show less subsidence. So different cage materials, essentially 3 major options. You have autograft, which has historically been the gold standard, but has surgical site morbidity, operative time, and limited supply with the biohost, and then also has difficulty with size and shaping and may require more futzing with intraoperatively to make it work. Structural allograft has limitations as well with respect to graft resorption and settling, as well as disease transmission, and some variability between the graft. And then the third option, the major option that is utilized nowadays, is synthetic cages, PEEK, titanium, all the other ones we've talked about. Those have an increased cost and may not be as biologically active. Looking at a couple of those materials, titanium cages were among some of the first used. This had led to, like we talked about, the stability as the priority, but then subsequently changes to the actual mechanical alignment led to more change, or the focus on the change in mechanical alignment led to focus on changes in shapes and sizes of the different implants. The titanium cages kind of were used early on, promotes healing of the bone of the cage itself, while also having sufficient strength from the initial insertion. There was some thought to be increased subsidence secondary to higher modulus of elasticity, and there was limitations with postoperative radiographs just with artifact. This kind of led to the development of PEEK, assessing some of the drawbacks of those early metallic cages, initially described in 1989. They're inexpensive, they're radiolucent, and the modulus of elasticity approximates cortical bone, which may decrease the stress shielding like we talked about previously. However, they don't really integrate into the bone. There's typically a fibrous tissue formation around the edges of the inner body, which may be seen in other materials as well, but it's more so in PEEK. There is some thought of pseudoarthrosis as well as cage migration, and then some weak surfaces on the cages, especially at the interfaces with the end plates, can cause cage fracture during insertion. So then kind of trying to combine the best of both worlds or have a hybrid between the two. This is looking at the surface treatments, essentially hydroxyapatite coated titanium, titanium coated PEEK, which was thought to improve the bone formation and integration. It does still have a weaker surface interface and can still be prone to cage fracture on implantation. There also is some thought of wear debris, but this is typically thought not to be as locally reactive as some other areas, especially like total hip arthroplasty or something like that. And there's potential for 3D printed technology to be used in these implants. This was looking at the effect of smooth versus porous titanium. So again, trying to get additional fixation from previously used materials with respect to osseous integration. Essentially, they found that osteoblasts cultured on the rough textured and the porous textured titanium had significantly higher rates of bone-specific extracellular matrix syntheses and subsequent mineralization. So the rough textured or the porous coated titanium improved or performed much better than the smooth coated titanium. You guys in here?
I think this is for you guys. Is this for nurses week or?
Sorry, we're getting some food delivered.
It says Ortho Conference.
Oh, okay.
I think it's for nurses week though, because weekend, I think they were doing coffee and something else. So.
Okay. All right. Sorry, I'll keep going. So this was another early paper looking at grit blasting of the titanium surfaces. Essentially, it showed a higher ability to resist shear forces with a rougher texture, specifically in titanium. So again, smooth versus rough, the rougher performs better. This was looking at bony ingrowth potential of 3D coated porous titanium. In an article from Spine in 2018, essentially they compared different cages in 27 different sheets. The surgeries were done at L23 and L45. They looked at peak, the plasma sprayed porous coated, as well as the 3D titanium alloy. And they assessed fusion at 8 and 16 weeks, both kinematic, like motion analysis, a CT scan, and histologic sections as well. They found no difference in range of motion with flexion and extension or lateral bending between the different groups at 8 and 16 weeks. And then they found that the ingrowth and on-growth with 3D cage was superior to peak, which theoretically leads to more stability. Though, like I mentioned earlier, they all had the fibrous tissue surrounding the implant surface, but peak did have more than the others. So this is again looking at the titanium coated peak, the sheep model demonstrating significantly more bone by micro CT qualitative grading when compared with peak. And the histology showed newly formed woven bone tracking to the surface between the armatures. So this is porous peak as a newer material. Essentially, the animal work has demonstrated greater incorporation of porous as compared to smooth, also with greater pull-out strength, similar to kind of everything else we've talked about. Having the additional pores or rougher texture can aid in healing. Moving on to disc arthroplasty. So starting with cervical disc replacement, essentially, this is a brief overview of different implant design. The goal of arthroplasty, obviously, is to maintain normal motion through the disc space if possible. Primarily, these implants have 6 degrees of freedom with rotation and translation in all 3 axes. And then they can be characterized by how many different factors or how many components they have, which we'll get to on the next slide. This is kind of the first, modern design approved in 2007 by the FDA. It's a stainless steel ball and socket design. Its most recent iteration, the Prestige LP, is a titanium ceramic composite with porous coating and designed to promote ingrowth. So you can see that on the lower part, and then the original design is the upper image. But overall, they can be quantified by the components. So 3 component options are the Simplify, the MobiC, and the Secure C, looking from left to right. The Simplify is one that we'll frequently use. It's got the ceramic inner core with the superior and inferior end plate options. And then the MobiC is cobalt chrome with the hydroxyapatite coating and high molecular weight polyethylene core. These are the options available for 2-component discs. The Pro Disc C cobalt chromium with roughened titanium end plates to promote bony ingrowth, again with ultra high molecular weight core. And you can see each of those has 2 components, no freestanding inner piece. And then non-articulating, these are older implant designs that you can see there. Lumbar disc arthroplasty, originally described in 1950, very similar to cervical disc, a stainless steel ball in place of the nucleus pulposus. You can see a kind of original image there of what that would look like radiographically, but stainless steel being utilized historically in the past stays consistent from cervical to lumbar. And then in the 1980s, this was pushed to be a commercially developed product, utilized very similar technology to hip and knees. And then consisting of a polyethylene core between 2 metallic end plates, as a lot of the other designs are as well. So these are mostly the Pro Disc or the Maverick are the two that I'll highlight. The Pro Disc is very similar concept with the polyethylene core attached to the inferior end plate, and then it only articulates with the superior end plate, which is a little bit different. And then the Maverick is metal on metal with cobalt chrome end plates and bearing surfaces. So that's all I have. Wanted to touch on a kind of variety of topics, see how some of these biomechanical principles would apply with pedicle screws and other implants that we use, and then a brief overview of arthroplasty. But if anyone has any questions, I'd love to stick around for discussion.
Okay, Mike, I got one for you.
Okay.
So which cervical disc replacement will you use in practice and why?
That is a good question. The easy answer is simplify, because it's what I'm familiar with from being here, and I'd like to not change too many things initially when I start. But I think there's a lot of debate with that, especially when you look at like metal on metal versus metal on poly and different rates of adjacent segment disease. I don't think there's one solid answer, but I would probably stick with the simplify just because it's what I know.
Right. Well, is there any other benefit to simplify over the other one?
I think the ceramic core plays a big role compared to like a metal on metal construct, which may have more favorable biomechanics at the instrumented level, but long term it can pass on more of the forces to adjacent segments and have higher rates of adjacent segment disease.
Right. I guess my question is also along the lines, there's twofold. Do we have any head-to-head comparative long-term studies on the different disc designs when compared to each other?
No.
Is anything out there? I don't believe there is.
Yeah,
Right?
I'm not familiar with anything.
Yeah, almost all the studies are looking at longevity and sustainability of these things compared to fusion, but not compared to themselves or each other, right?
Correct.
Right. So we don't know adjacent segment rate failures for the different designs compared to the other designs, correct?
Correct. Yeah. I don't think
Good.
there's any like head-to-head studies. I think there's been some that look at like general trends, just in materials, but not necessarily head-to-head for the implants themselves.
Right. So I think the part of the reason I think, at least in my practice, why I'm doing simplify is because of the radiographic benefit after surgery. In other words, I can do an MRI, and because it's a peak-based implant, I'm not seeing the artifact, so I can actually see the levels I've treated radiographically on an MRI. And to me, that's an enormous benefit for the patient post-op.
Yep.
So that is the primary reason. I think it's mechanically equivalent to everything else. I don't think we can say anything else but that. But radiographically, it is a unique design. I don't think there's anything else available right now on the market that gives us those radiographic parameters post-op. Does anybody else have any aware of anything else like that?
Nope. Yeah, I think that's right, Jane. We don't have the long-term results on the simplify to
Right.
the 10 years that you have on some of the others, but
Right.
yeah, the MRI compatibility in terms of visualization is definitely an upside.
Yeah, if you have equivalent biomechanics, in my opinion, Mike, if you have equivalent biomechanics, hopefully theoretical will have equivalent longevity, and then from a radiograph, there's a radiographic. To me, there's a radiographic superiority here, just in terms of postoperative imaging. So that's how I look at it. If all other things be equal, I'm hoping. We don't know because we don't have the long-term data, but I'm hoping that is they play out so it's just as good as everybody else's and anything else, but it's got the radiographic benefits. So, and then here's my other question for you: which interbody technology you're going to put in, and why?
I mean, my initial answer is kind of the same with what you're familiar with. I think the 3D like porous titanium has probably the best data behind it with respect to like the evolution of implants. And I think we use a lot of that here anyways. So yeah, I mean titanium.
You're going to use the porous titanium. Okay.
Yeah.
So Mike, I'm not sure I love the answer. It's what I know from fellowship. That sounds like a TBI fellow answer. How about a little more thoughtful exploration as to why you would do it based on your analysis?
Yeah, I mean, I don't, obviously that's not the whole reason. I think what I mean by that is just that you would have to have, or I would have to have a good reason to switch. And when I look at the different interbody options, I would use the ones that we use anyway. So the
Why?
titanium,
Why? Give me a
because
why.
I think it has the best data with returns with respect to both the basic sciences, like the different surface coatings that we talked about, like the hydroxyapatite coating. We use those in the SI bone implants, the different 3D like porous coated titanium we use. So I think that's got the best data. You could make an argument for peak, especially with radiographic
Okay,
findings, but
when you say best data, talk to me about data. What kind of data are we? What data do you use to justify your choice? Is it biomechanics? Is it basic science? Is it cost? Is it clinical?
Yeah. Is it outcomes? Is it fusion rates? Is it
So
maintenance of
how
alignment? All right. Right.
you should choose your implants based on all of those things, not
yeah,
what you saw in fellowship. You know what I
agreed.
mean?
Yeah.
Yeah.
And I know it's a biomechanics talk, but you go out into practice. My hope is that everything you choose is a compilation, best you can find, of evidence in each of those arenas.
Yeah, Bob, that's
And
a great way
sometimes
to,
there's a positive.
yeah, that's a great way to frame it because it's a biomechanics talk. So
Hmm?
in your mind, Mike, after doing this
Is it
research and
not?
going through this, what's the
You want,
best
you just want to do your
biomechanical
wrist and your
interbody, do you
finger
think?
separately?
Hey, Greg,
Um,
you want to mute?
Oh, sorry.
I don't know. I don't know definitive answer to the best biomechanical interbody because I think that's a pretty broad topic. Like obviously biomechanics are going to have a lot to do with size and shape and that sort of thing. I think the best biomechanical data is out of the 3D porous coated or porous titanium as far as like from in context of this talk is my understanding of it.
Best biomechanical from what perspective? Like, are we talking about construct stiffness, modulus?
Yeah, I mean, so this is like probably the study I would point to is that it like all the above. So construct stiffness, so like kinetic motion analysis, looking at like peak versus plasma coating or not. Um, I think the like fibrous layer being greater in peak. I think peak typically, although I don't have any of the data in this talk, has a higher pseudoarthrosis rate, the cage migration concerns that we talk about. So I mean, yeah, it's kind of an all-encompassing answer with respect to stability to cell differentiation around the implant, ingrowth through the implant, and as well as on the implant compared to peak. I think overall, kind of everything would point in that direction, other than radiographic artifact.
And which is a um, structure that's closer matched to bone subsidence risk.
Peak,
Is that
like
true?
peak. I think peak is
So,
thought to generally have less subsidence because it's a closer elasticity.
well, right, as a material, right? But what's
Yeah,
the difference between a material modulus and structure stiffness? You know the difference between those two things.
no.
So if you
Well, I mean, yeah, short answer
when
is
you see
no.
when you see those charts and you see these differential substances with modulus and stainless steel on the top end and bone on the bottom end, those are pure material property assessments. If you change the structure of that material, you change the relative stiffness. So you can't look at materials in a simplistic modulus perspective anymore when you can modify their structure. Like I think the easiest way to conceptualize that is a spider web, right? Real spider web looks real flimsy, but it's really the tensile strength's amazing.
Mhm.
If you take metal and you restructure it into a lattice network, it's not going to have the same stiffness as you would consider the modulus solely based on the material itself. You can modify it in a sense, and so the surface topography, the trampoline effect, if you will, that occurs when you change the structural behavior of the material is going to modify, in a sense, what the actual modulus is. So you just have to kind of get more complex than the modulus of the material itself when you're talking about a structure. So that
Okay.
changes the whole argument. And then it's not so simply PEEK versus titanium alloy. Now you have to be thinking about the structure and how it's shaped and how it behaves as a structure rather than the material properties within. And that's all very different. So it's a rapidly moving area. In general, your PEEK can be less stiff, but that's not necessarily always the case depending on the structure of the metal. So then you get into not just the biomechanics, but the biology, right? And that can be modified now. And you can do the acid etching and the different surface treatment of a metal can markedly change the way it behaves, even though it maintains its hydrophilicity. It'll change the amount of cellular messaging and biologic behavior. And likewise, with PEEK, if you change its chemistry, if you put HA in it, you can basically mimic the way it or titanium serves. You can allow it to be more bioactive, and then its topography also can make a difference. So that there's porous PEEK, there's trabecular PEEK. There's all these different modifications that have bioactive influences, and then the complexity of the structural stiffness itself. So I mean, in the end, you may choose different material properties and structural stiffness depending on who you're working on. Like a real osteoporotic woman with a tall disc space is going to have lousy end plates. That'd be perfect for a subcortical level of structural stiffness that in a perfect world you could customize. You choose your implant accordingly, and hopefully they all achieve a bioactivity. That you get the drift. I don't want to beat the dead horse.
No, yeah, that makes total sense. I mean, I think it's kind of both of those things you talked about. Like a lot of this obviously have been focused on the material itself with the different metal part of the talk, but it's obviously also the configuration and different implant design itself that contributes to that as well, not just the material. So I think that makes sense.
Yeah,
Any
Mike,
other comments?
I think the final thing there, as you're picking stuff, is also your ability as a surgeon to follow your outcomes from a radiographic standpoint, to see if they are fusing. I think that's a factor, certainly is a factor in how I choose my implants, to be able to see radiographically with a moderate amount of certainty that the patient is doing what you intended to have them do, which is to heal a fusion, right?
Mm-hmm.
So there's drawbacks and to certain materials versus others, simply based on design of implant, right? Material implant, design of implant, all those things factor into your ability to see what's going on post-operatively. So those are other factors you have to. It's just like the disc replacement. So why you choose something, right? If all other things are equal.
Mm-hmm.
Just one more thing.
And then, and we may not have made it clear, Mike, but we're also thinking about it economically. The part of the reason that I've chosen what I use anyway is I can dial back and use very little biologic heft and still get a real high fusion rate. So there's the health economic part of the decision too, in what you choose.
Mm-hmm.
Yeah. The improving biomaterial is driving down the overall cost. Bob's exactly right on that. As we've gone for PEEK to coated PEEK type materials, you're also hopefully seeing the need for either less expensive biologic or less volume of biologic, which is a great thing. That's all we got.
Right. Thanks, Mike. Good dive
Awesome.
there.
Thank you, Mike. Yeah, thank you.
Thank
Thanks,
you guys.
Mike.
I appreciate the
Appreciate ya.
discussion.
All right. Have a good day, everybody.
Yeah.
You too. One last comment here, Mike. Like
Oh, yeah.
one of the reasons this talk's important is because people are gonna sell you stuff all the time, and you just have to be aware of the potential benefits that you're being sold versus what's not, what doesn't make sense, you know what I mean? And it's important for you guys to have these biomechanical considerations in mind and to be experts in them. And to just take someone's word for it is not okay. And we love our sales teams, you know, like they're wonderful people, but at the end of the day, companies, they only make money by selling you stuff, which is fine as long as you're, you know, aware. So don't always just take things at face value and you know, demand the due diligence that's necessary for you to change your practice. And a lot of what you touched on is that due diligence. So as you get busier in practice, it's harder to keep up with some of this stuff. So having a good fundamental knowledge, I think, is critical as you try to take care of your patients. So just a comment.
Comment, Greg.
Yeah, awesome. Thank you.
All right, guys, have a great day.
Thank you too.
Thank you, everybody.